Next is Dr. Meena Chakrabarti. She is one of the senior most practicing vitreoretinal surgeons in India. She is the heart and soul of this instruction course. She will be dealing with cluster endophthalmitis.
Thank you, Thomas. In the August of 2018, I had the fortune, or I would rather say the misfortune, of dealing with a cluster endophthalmitis referred to be my colleague. I had 4 patients who had endophthalmitis. All had undergone surgery on the same day, and everyone proved to be culture positive for ACINETOBACTOR BAUMANNII infection. So if you look at this pathogen, it is a gram-negative Coccobacilli, which belongs to the Moraxiliaceae family. It's a red alert pathogen, and it is part of the escape group of organisms which cause very severe nosocomial infection. It is ubiquitous, present everywhere. It can be a normal flora of the perineum, the oropharynx, and it can also grow on antibiotic eye drops. It's a multi-drug resistant organism causing recalcitrant infection. So I thought I could collect all the records by retrospectively analyzing my case sheets and present to you. They present all the 4 cases operated at the same center, presented at varying periods of time from 2 weeks to 4 weeks after the primary surgery. The best corrected visual acuity was not more than hand movements in any of these patients. They had either chalky white or gelatinous brownish dirty colored hypopyon. One patient had a limbal infiltrate, and one patient had a partially treated, partially steroid responsive. She had already undergone a vitrectomy. Her capsular bag had sequestered organisms. She had an epiretinal membrane and macular edema. All the patients were culture positive for ACINETOBACTOR BAUMANNII infection, which is sensitive to ceftazidime, ceftriaxone, cefpirozone, piperacin tazobactam, and I decided to give ceftazidime. They underwent an average of 8 biopsies. Each time the biopsy was positive for ACINETOBACTOR BAUMANNII, the aqueous, the vitreous cavity, the explanted IOL, and the capsular bag were all sent for culture. An average of 8 intravitreal injection was given, initially vancomycin with ceftazidime, followed by ceftazidime alone. An average of 4 vitrectomies was done in each of these cases. Case 2 and case 4 an epiretinal membrane peel, and 1 case had persistent hypotony in the postoperative period and needed a silicone oil tamponade. I'll share with you the difficulties I encountered with one patient. It is a one-eyed patient, and this was her only eye. The other eye was lost following trauma. I have our data from the 10th month. The first 2 months pictures are not there. This is after post-intravitreal vancomycin, ceftazidime, and 2 episodes of vitrectomy. The eye looks fine. So this is in the 11th month. You can see the gelatinous dirty white hypopyon collecting in the anterior chamber. The posterior chamber, surprisingly, had very little inflammation. It was confined mainly to the anterior segment. I tried advising her to undergo an IOL explantation. Since she was one-eyed, she did not want to give up her lens. So this is in the 11th month, after again another intravitreal injection and topical ceftazidime antibiotic drops, her inflammation subsided. She came back again in the 12th month with recrudescence of the infection. This is the 12th month picture. The same thing in January, and by February I had almost given up. I told her that we have to explant the IOL, and then she agreed. This is what the eye looked at the time of IOL explantation. You can see the amount of muck in the anterior chamber. It's like a cocoon in the anterior chamber, and when you puncture it, you can see fresh exudate coming out of it, as if the entire thing is coated with a fibrin membrane. She had a single piece hydrophilic acrylic lenses implanted in the bag. There was a lot of addition between the iris and the IOL. The IOL is brought out of the capsular bag, and in these situations, you have to explant the IOL together with the entire capsular bag. Try to carefully remove the entire capsular bag. With the organism may be sequestered in the capsular bag in the ciliary sulcus, and it can grow again and cause recrudescence of the infection. So the IOL comes out. It is cut and explanted. The anterior chamber is cleared. I've already taken a biopsy again at this point of time, both from the anterior chamber and from the vitreous cavity, and you'd be surprised to see how at the end of the surgery, how clean the eye looks like. The eye is basically white. There is hardly any congestion or chemosis in this patient, and there is no discharge also. And you can see there's a red glow also in this patient. This is in March. He had a best corrected visual acuity with FAK correction of 6/24, and we could get some fundus view. So these are 4 culture-proven cases, all at post-surgical, post-cataract surgery endophthalmitis. They underwent multiple intravitreal injections and posterior segment procedures. Case 1 ended in phthisis. He somehow gained enough confidence in our center to have the other eye operated for us, and he is doing well. Case 2 I have already discussed. Case 3 ended with a vision of 6/18. Case 4 had persistent hypertony. If you look at the susceptibility of this organism, it varies in different studies, varies with time, varies with the location. Some are sensitive to the fluoroquinolone, some are not. My patients were sensitive to, luckily for me, to ceftazidime, which we can inject both intravitreally and also prepare the ceftazidime eye drops. So I contacted the surgeon, and we decided to suspend all surgeries in his theater. We reviewed all his, both of us together reviewed all his protocols. Full assessment of his perioperative protocols, the patient preparation, the operating theater hygiene, instrument sterilization, everything, single aspect, and nothing faulty could be brought out. All traceable materials used during that period of time was collected and cultured, again negative. The environmental sampling from the theater, the air conditioners, the surgical instruments, the operating floor, and the surgical personnel, operating room personnel, everything was done, everything was negative. But when the patient first came to me, the case number 2, we have a protocol in which we examine the patient's eye drops, especially if it's an infected case, and I saw that there was a lot of crusting, and I cut out the dropper of the antibiotic drop and sent it for culture. It yielded something, but the lab reported it as a contaminant. So ACINETOBACTOR BAUMANNII is a gram-negative coccobacillus. It forms a biofilm on all surfaces, especially dry surfaces, the operating room surfaces. It can also grow on the dropper tip of the antibiotic dropper tip. So we have to be very careful when we advocate antibiotic use or other eye drop use for a long period of time. Please check the bottle droppers. So my ordeal ended in March. From August of 2018 to March of 2019, I had literally had these 4 patients eating from my head. Even now, right from the names, I can remember every single detail. 2 of them have done well. One has good vision in his fellow eye, and one is a vision of 6/60 with a little hypertony. I'm replacing the silicone oil every 2 yearly. I thank you very much for your patient hearing.